Welcome. I am Dr. Tracy Nichols, a professor of public health education at UNC Greensboro. Today, I am presenting on a study that I and my co-authors conducted on structural and social stigma in perinatal substance use service delivery. We know using substances while pregnant and/or parenting is highly stigmatized, and that stigma leads to a decrease in the use of healthcare and social services that are critical for the health and well-being of both parent and child. Stigma in service delivery creates barriers to accessing and engaging with needed services and can decrease clients' disclosure of drug use during care interactions. The stigma is intersectional, consisting of multiple overlapping biases towards substance use disorders, the type of drugs used, and towards harm reduction approaches. The intensity of stigma against pregnant and parenting people who use drugs differs by race, ethnicity, and class, with harsher condemnation and discriminatory practices targeted towards low-income people and parents of color. Stigma is multi-level, with processes at the self, social, and structural levels. Structural stigma is difficult to make visible, increasing its ability to perpetuate and reinforce social and self-stigma. A better understanding of stigma processes at the structural level has the potential to create greater and more lasting change. Using an intersectional lens, this study examined the interplay of structural and social stigma in service delivery to gain a deeper understanding of how stigma can serve as a pathway to health inequities. The study used a constructivist grounded theory design. The setting was North Carolina, and data collection lasted 7 years. Interviews and focus groups were conducted to include the perceptions and experiences of service professionals. We conducted observations of meetings and dissemination events where service delivery was discussed, and we collected publicly available documents on relevant policies and practices. Data underwent open and focused coding, combined with extensive memoing, diagramming, and team discussions of the meaning being constructed from the data. The system that pregnant and parenting people who use drugs must navigate is embedded in a sociocultural context that is itself a form of structural stigma. This system consists of multiple, overlapping, and often competing regulations and a shortage of resources. Regulations include mandates on parental surveillance and reporting of drug use, eligibility requirements, and how policies and practices are enacted within institutions. Resources include the underfunding of professional services, along with a shortage of personal resources like housing, employment, and safety. Access to care through insurance and transportation, as well as issues affecting the training service professionals, lie at the intersection of resources and regulations. Structural forces both affect and are affected by the attitudes, beliefs, and behaviors of service professionals that enact social stigma. A common stigma reduction approach is training professionals, but in the absence of structural level changes, this becomes another form of structural stigma. Applying an intersectional lens highlighted how the intersection of multiple marginalizations exacerbated inequitable care engagement and outcomes. Precarious vulnerability represents multiple deprivations and insecurities that both complicate clients' ability to navigate systems of care, as well as are exacerbated by the requirements of these systems. I've included 2 examples. The first is from a dissemination toolkit. Services may be fragmented, requiring a woman to negotiate a maze of service agencies to obtain assistance for housing, transportation, childcare, substance abuse treatment, vocational training, education, and medical care. In addition, many agencies have requirements that conflict with each other or endorse repetitive intake processes, including different forms that gather the same information. The second comes from a social service professional and highlights the intersection of social and structural stigma. It's just tragic to see the way people understand it. They just look at the person and say, well, they're an addict and they're just getting pregnant willy-nilly and all these kinds of things without really understanding what's going on. There's no easy solutions, but we know things that work. But people are not motivated to put money into it and fund it because, frankly, a lot of people just don't care. Our study demonstrates how intensive requirements combined with a lack of resources are being placed upon the most vulnerable people and ensuring their failure. By identifying and describing interconnections of structural and social stigma, we can develop more effective stigma reduction strategies. Thank you.